So good morning, class. So today we're going to be going over chapter 12, shock. Shock and resuscitation applies fundamental knowledge of the causes, pathophysiology, and management of shock, respiratory failure or arrest, cardiac failure or arrest, and post-resuscitation management. Pathophysiology applies fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Shock, also known as hypoperfusion, describes a state of collapse and failure of the cardiovascular system. In the early stages, the body attempts to maintain homeostasis. So what does homeostasis mean? A steady state. Remember hemostasis, the stopping of blood flow. As shock progresses, blood circulation slows and eventually ceases. Shock can occur because of medical or traumatic events: heart attack, severe allergic reaction, motor vehicle crash, gunshot wound. EMTs respond to different types of emergencies to provide care and transportation. They must be constantly alert to the signs and symptoms of shock. Perfusion is the circulation of an adequate amount of blood to meet the cell's current needs. The body is perfused via the circulatory system. Organs, tissues, and cells must have adequate oxygenation or they may die. So remember, we've gone over capillary refill when we're checking CSM, when we're splinting, when we're backboarding, before and after. We want to make sure that patients' extremities are getting good blood flow or good perfusion. Cases of poor perfusion, shock, transportation of carbon dioxide out of tissues is impaired. Results in dangerous buildup of waste products, which may cause cellular damage. Shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. Shock is an unseen life threat caused by a medical disorder or traumatic injury. So different types of shock can be caused by either medical or traumatic injuries. If the conditions causing shock are not promptly addressed, death may soon occur. Cardiovascular system consists of three parts: the pump, also known as the heart, set of pipes, blood vessels or arteries, contents, the blood. So this is a pretty good picture. So you got your inferior vena cava, you got your superior vena cava. So deoxygenated blood is coming into the heart, the left atrium. It's going to go down to the left ventricle, and then it's going to be pumped to the lungs. It's going to get perfused, or it's going to get oxygenated, and it's going to come back into the left. I'm sorry, this is the right. Blood is going to come in through the right atrium, go down the right ventricle, back into the lungs, and then back into the left atrium, and then down to the left ventricle. And then out the aorta to the rest of the blood. So, and then this is your septum wall. So it divides the left and the right of the heart. So these three parts can be referred to as a perfusion triangle. When a patient is in shock, one or more of the three parts is not working properly. So heart, pump function. Damage to the heart by disease or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support perfusion. Blood vessels, container function. If all the blood vessels dilate rapidly, such an anaphylactic shock, the normal amount of blood volume is not enough to fill the system and provide adequate perfusion to the body. So blood content function. If there is enough blood or plasma loss, the volume of fluid in the container is not enough to support the perfusion or needs of the body. So if the patient's bleeding out, they're probably not going to have enough blood flow. So that would be hemorrhagic shock. Blood pressure is the pressure of blood within the vessels at any moment in time. So systolic, peak arterial pressure. Diastolic, pressure in the arteries while the heart rests between the heartbeats. So how do you do blood pressures? First number is going to be systolic, right? The second number is going to be diastolic. And they're always going to be even numbers, correct? You're not going to tell me they have a blood pressure of 139 over 87. It's going to be 140 over 88. Pulse pressure is the difference between the systolic and diastolic pressures. Pulse pressure signifies the amount of force the heart generates with each contraction. A pulse pressure less than 25 millimeters of mercury may be seen in patients with shock. Blood flow through the capillary beds is regulated by the capillary sphincters under the control of the autonomic nervous system. Capillary sphincters respond to other stimuli, heat, cold, the need for oxygen, and waste removal. Perfusion requires more than just having a working cardiovascular system. Adequate oxygen exchange in the lungs, adequate nutrients in the form of glucose in the blood, adequate waste removal, primarily through the lungs. Mechanisms are in place to help support the respiratory and cardiovascular systems when the need for perfusion of vital organs is increased. Mechanisms include the autonomic nervous system and hormones. Hormones are triggered when the body senses pressure falling and causes an increase in heart rate, strength of cardiac contractions, peripheral vasoconstriction. So when the body thinks it's going into shock, it's going to start increasing your heart rate so you could pump out more blood. Your heart's going to contract a little stronger. Or it's also a peripheral vasoconstriction. So what happens in shock is the body starts sending blood back to the main areas of the body, back to the vital organs, to keep those perfused. So you're going to have not as much blood flow on your extremities, because most of the blood flow is going back to the center of your body. Together, these actions are designed to maintain pressure in the system, sustain perfusion of all vital organs. It is this response that causes all the signs and symptoms of shock. Causes of shock. Shock can result from bleeding, respiratory failure, acute allergic reactions, and overwhelming infection. Damage occurs because of insufficient perfusion of organs and tissues. So remember, if you don't get enough oxygen to the organs and tissues, they're going to start suffering damage. They're going to start dying off. So, a couple causes of shock. Pump failure causes heart attack, trauma to heart. Obstructive causes, large pulmonary embolism, basically a clot. So, low fluid volume causes trauma to vessels or tissues. Fluid loss from GI tract, vomiting, diarrhea can also lower the fluid component of blood. So anybody who's been sick and thrown up a lot, having diarrhea, could have low blood volume because of all the fluid that they've lost, because they're probably not putting as much fluid back into the body. So poor vessel function causes infection, drug overdose, narcotic, spinal cord injury, anaphylaxis. So if a patient is septic, like in an infection, they could have poor vessel function and not getting enough blood flow to the rest of their body. So the different types of shock we have are going to be the main four. It's cardiogenic, obstructive shock, distributive shock, and hypovolemic shock. Okay, so obstructive shock, tension pneumothorax, is going to be a collapse in the lung wall. Cardiac tamponade, there's going to be fluid around the heart. Pulmonary embolism is going to be a clot. Septic shock is going to be an infection in the blood. Okay. Anaphylactic shock, an allergic reaction. Hypovolemic shock, hemorrhagic shock. So if you're losing blood, non-hemorrhagic shock. So if you're losing fluid somewhere or somehow, and then instead of blood, it's going to be non-hemorrhagic shock. So cardiogenic shock, caused by inadequate function of the heart. Major effect is the backup of blood into the lungs. resulting buildup of pulmonary fluid is called pulmonary edema. Edema is the presence of abnormally large amounts of fluid between cells and body tissues, causing swelling. Pulmonary edema leads to impaired respiration, which may be manifested by an increased respiratory rate, abnormal lung sounds. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. Obstructive shock, caused by mechanical obstruction that prevents an adequate volume of blood from filling the heart chambers. Three of the most common examples: cardiac tamponade, tension pneumo, thorax, pulmonary embolism. So cardiac tamponade, collection of fluid between the pericardial sac and the myocardium, pericardial effusion, becomes large enough to prevent ventricles from filling with blood, caused by blunt or penetrating trauma. Signs and symptoms are referred to as Beck triad. So you guys can't do anything for this type of shock out in the field. This person needs to see a doctor or surgeon, so they could go in and stick a needle in their heart and pull out all the fluid between the pericardial sac and the myocardium. Tension pneumothorax, caused by damage to lung tissue. The air normally held within the lung escapes into the chest cavity. The lung collapses and air applies pressure to the organs, including the heart and great vessels. So, signs and symptoms of tension pneumothorax is asymmetrical wall movement, low SpO2. So, pulmonary embolism, a blood clot that blocks the flow of blood through pulmonary vessels. If massive, can result in complete backup of blood in the right ventricle. It leads to catastrophic obstructive shock and complete pump failure. Distributive shock results from widespread dilation of small arterioles, small venules, or both. The circulating blood volume pools in the expanded vascular bloods. Tissue perfusion decreases. So a type of distributive shock is going to be an allergic reaction. Your vessels dilate and they start leaking fluid, they start leaking plasma, and the blood volume decreases. So septic shock occurs as a result of severe infections in which toxins are generated by bacteria or by infected body tissues. Toxins damage vessel walls, causing increased cellular permeability. Vessel walls leak and are unable to contract well. So this is an infection within the bloodstream. This is a serious condition. So widespread dilation of vessels in combination with plasma loss through the vessel walls result in shock. Neurogenic shock, usually a result of a high spinal cord injury. Causes include brain conditions, tumors, pressure on the spinal cord, spina bifida. So muscles in the blood vessel walls are cut off from the nerve impulses that causes them to contract. So anaphylactic shock occurs when a person reacts violently to a substance in which he or she has been sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure tends to produce a more severe reaction. So anaphylactic shock, if you've already been exposed to something and it didn't cause an allergic reaction, it might cause an anaphylactic reaction, which is more severe. So 4 categories of exposure include injections, tetanus, antitoxin, penicillin. So remember, you're always asking people, are you allergic to anything? So penicillin's a common one that people are allergic to. Penicillin, sulfa. So stings, wasps, bees, hornets, ants. Ingestion, fish, shellfish, nuts, eggs, medication. Inhalation, dust, pollen, mold. So it develops within minutes or even seconds of contact with the substance. Second phase reaction can occur 1 to 8 hours after initial reaction. Signs are very distinct. Cyanosis, blue discoloration of skin, is a late sign. So the table right here gives you different signs and symptoms of anaphylactic shock. The skin, circulatory, respiratory system. Other. So skin, flushed, itchy, burning. Urticaria, which is going to be hives. Edema. So patient's face can swell up. The arms can swell up. Cyanosis. Circulatory system is going to be dilated peripheral blood vessels. Increased vessel permeability. Drop in blood pressure. Respiratory system is going to be sneezing, itching. Stridor, upper airway obstruction, tightness in the chest, wheezing, difficulty breathing, constriction of the bronchi. Okay, so other common symptoms can be abdominal cramping, nausea, vomiting, ALOC or altered mental status. Psychogenic shock, caused by a sudden reaction of the nervous system, produces temporary generalized vascular dilation, results in fainting, syncope. Some causes are serious and others are not. Life-threatening causes include irregular heartbeat and brain aneurysm. Non-life-threatening events include receipt of bad news or experiencing fear or unpleasant sights such as blood. So first time I did an IV in anybody, and this happens a lot to people when they give blood. Once they see their own blood, they can faint. My first IV on somebody, I didn't hit it, and he started bleeding and he fainted on me. So hypovolemic shock, result of an inadequate amount of fluid or volume in the circulatory system. Hemorrhagic causes and non-hemorrhagic causes. Occurs with severe thermal burns. Intravascular plasma is lost. Dehydration, loss of water or fluid from body tissues, can cause or aggravate shock. Fluid loss may be a result of severe vomiting and or diarrhea. So any of you guys have been sick with pneumonia or the flu, you guys lose a lot of water because your body's not retaining it. Your blood vessels are dilating. You're getting that vasodilation. You're getting permeability. You're getting third spacing. That fluid's leaving the vessels. And you're also going to the bathroom a lot. You're vomiting. You have diarrhea. So you have to be careful. You got to keep your fluids, your electrolytes in you. So respiratory insufficiency. A patient with severe chest injury may be unable to breathe in an adequate amount of oxygen. An insufficient concentration of oxygen in the blood can produce a life-threatening situation as rapidly as vascular causes of shock. Anemia is an abnormally low number of red blood cells. So this could cause a shortness of breath. What do red blood cells do for the body? Red blood cells transport oxygen and the hemoglobin. So people with anemia can get short of breath pretty quickly. So it's important to possibly think about giving oxygen to these patients because they're not getting enough oxygen in their blood cells. Hypoxia occurs because blood is unable to deliver adequate amounts of oxygen to the tissues. So certain types of poisoning may affect the ability of cells to metabolize or carry oxygen. So carbon monoxide poisoning, cyanide poisoning. So we've talked about carbon monoxide poisoning. If you bring somebody out of a fire that's been in the house and you put them on SpO2, their SpO2 might read 100%. But remember, carbon monoxide binds to hemoglobin about 254 times more than oxygen. So just because they're reading a good SpO2 reading doesn't mean they don't give oxygen. Just go ahead and give them oxygen. Okay? Remember, treat your patient, not the monitor. So the progression of shock. The stages in the progression of shock. Compensated shock. Early stage when the body can still compensate for blood loss. So an increased heart rate, increased respiratory rate is going to be some signs in the compensated shock. So decompensated shock, late stage when blood pressure is falling. When it gets to a certain point, it's going to be decompensated shock. And no way to assess when effects are irreversible. Once a patient loses a certain amount of blood, there's nothing you can do to help them. Okay, so remember, you got to act fast. Must recognize and treat shock early. So signs and symptoms of shock. So compensated shock. It's be agitation, anxiety, restlessness. Feeling of impending doom is a big one. If a person tells you they feel really bad and it sounds like impending doom, you got to listen to your patient. Okay? Altered mental status. Weak, rapid, or absent pulse. So shallow, rapid breathing. Capillary refill of longer than 2 seconds in infants and children. Narrowing pulse pressure. So decompensated shock. Falling blood pressure. So systolic blood pressure of less than 90 or lower in adult. Labored or regular breathing. Ashen, mottled, or cyanotic skin. Thready or absent peripheral pulses. Dull eyes, dilated pupils, poor urinary output. So blood pressure may be the last measurable factor to change in shock. When a drop in blood pressure is evident, shock is well developed. Particularly true in infants and children. Infants and children have a great ability to compensate, and then they kind of drop off a cliff. So you have to really be careful with infants and children when you're treating them and you think they might have been involved in a serious event, serious medical issue, serious trauma issue. They compensate for a lot longer than adults do. But then once they drop in decompensated shock, they deteriorate pretty fast. So expect shock in many emergency medical situations. So also expect shock if the patient has any one of the following conditions. Multiple severe fractures, abdominal or chest injury, spinal injury, a severe infection, a major heart attack, anaphylaxis. So scene size up. Be alert to potential hazards to your safety. Remember, you're always looking out. Even just because you got on scene and you think the scene's safe, you're constantly looking around to confirm that the scene is still safe, that there's no other hazards that might pop up. Use gloves and eye protection for trauma scenes or if bleeding is suspected. So in incidents involving violence, make sure police are on scene. Don't go on a scene unless it's safe. If a scene you think is going to become unsafe or patients or bystanders might be getting violent on scene or it looks like it might go that way, you could always ask for police. So primary assessment, perform a rapid exam, determine the level of consciousness, identify and manage life-threatening concerns, determine priority of the patient and transport. So when you get on scene and you see your patient, you're assessing them right away. You're looking at them. How are they sitting? Or where are they? Are they laying down? Are they sitting up? Are they on the ground? Do they look short of breath? Do they look in distress? Are they conscious? Are they looking at you as you're walking through the door? Do they look like they're breathing? Okay. And identify and manage any life-threatening concerns. Do you see any arterial bleeding? Do you see any type of bleeding? Do you see anything that could be potentially life-threatening as you're walking in the door? And then you're going to determine the priority of the patient. It's going to be scoop and go, or are you going to stay and play, like they say? So if a patient's critical, you're probably going to scoop and go as soon as you can. If you don't think a patient is critical, you're probably going to stay and play. You're going to kind of figure out what's going on with the patient. And then make your priority of the patient then, and then transport. So provide high flow oxygen and assist in perfusion. So anybody who's not perfusing well, you're going to give them oxygen. So for hypoperfusion, treat aggressively and provide rapid transport. Request advanced life support, ALS, as necessary. If you think the patient's going to benefit from advanced life support or paramedics, you should call for them early. Because remember, they still have to get the call. They still have to drive to on scene. Form a general impression. What do you think about this patient? Okay, assess the airway to ensure it is patent. Assess breathing. Listen to lung sounds. Put them on SpO2. An increased respiratory rate is often an early sign of impending shock. Assess patient's circulatory status. While you're talking to the patient, while you're assessing the airway and breathing, you go ahead and just grab their wrist and check for their pulse. Is it rapid, weak, and thready? Or is it strong and regular? Or is it irregular? It might tell you they might have a cardiac condition if it's an irregular heartbeat. They might have atrial fibrillation. So rapid pulse suggests compensated shock. In shock or compensated shock, the skin may be cool, clammy, or ashen. Assess for and identify any life-threatening bleeding and treat it at once. Determine if patient is high priority, if ALS is needed, and which facility to transport to. So try and figure out as early as you can and call for ALS. Because remember, they still have to get the call. They still have to drive to the scene and do their assessment. Okay. Trauma patients with shock or suspicious MOI, mechanism of injury, generally should go to a trauma center. So in our county, and for pretty much any book you're going to read, is they have 4 boxes. So 1 to 4. 1's going to be the most critical box, and 4 is going to be the least critical. If somebody falls within that category, you're most likely going to take them to a trauma center. But they always say, either in the book or even in our protocols, if you're suspicious at all that it might be a trauma patient, take them to the trauma center. Always err on the side of caution, no matter what. So history taken. Determine the chief complaint. Obtain a sample history. So why did they call you? What are they complaining of? What's the issue today? They having chest pain. They having abdominal pain. Respiratory distress. Anything like that. And then obtain a sample history. Signs and symptoms. What are they telling you what's wrong with them? What are you seeing that's wrong with them? Are they allergic to any medications? Do they take any medications? What's their medical history? When's the last time they ate or drank anything? And then what were they doing when the medical issue started? So your secondary assessment begins by repeating the primary assessment followed by focus assessment. If a life-threatening problem is found, treat it immediately. Obtain a complete set of baseline vital signs. Use monitoring devices. Okay. Reassessment. Reassess the patient's vital signs, interventions, chief complaint, ABCs, mental status. You're always reassessing the patient, no matter if it's stable or unstable. So if it's a stable patient, you're reassessing vital signs every 15 minutes. If it's an unstable patient, you're reassessing every 5 minutes. And interventions. What did you do to help that patient? Is it working? Is it helping? Did it make the problem worse? Did you give them any medications? Did you splint their leg? Did you splint their arm? Did you give them an ice pack? Okay. And reassess the patient's chief complaint. Did any of those interventions work for them? Are they feeling better? ABCs. Is their airway still patent? Are they still breathing okay? Are they still getting good circulation? Their mental status. Are they still ANO times 4? Are they still altered? Are they unconscious? Determine what interventions are necessary. Focus on supporting the cardiovascular system. Treat for shock early and aggressively by providing oxygen, keeping the patient warm. So, reassessment also helps too if you miss something the first time around. And this is why we always do reassessment. So, emergency medical care for shock. As soon as you recognize shock, begin treatment. Follow standard precautions. So, gloves at a minimum. If it's a trauma patient, you're going to wear glasses. You might wear a face mask or a face shield. Control all obvious bleeding. So, if it's an arterial bleed, you're going to control that right away. You're going to throw a tourniquet on. You're going to get direct pressure. Make sure the patient has an open airway. Make sure it's patent. Maintain manual inline stabilization if necessary, and check breathing and pulse. As soon as you recognize shock, begin treatment. Comfort, calm, and reassure the patient. Let the patient know that you're there for them, that you're doing everything you can Never allow patients to eat or drink anything prior to being evaluated by a physician. So this is always an important one. Don't let patients eat or drink anything. Just let them know the physician has to see them first. If spinal immobilization is indicated, splint the patient on the backboard. Provide oxygen and monitor patient's breathing. As soon as you recognize shock, begin treatment. Place blankets under and over the patient. So you want to conserve heat for patients who are in shock. They start losing heat. So placing blankets under and over the patient help. Consider the need for ALS. So another critical thing you have to think about too is, where's the nearest ALS unit? Where's the nearest trauma center? If you call for ALS and they're going to take 10 minutes to get there, but the trauma hospital is about 5 minutes away, I would probably go straight to the hospital. I wouldn't wait on scene for ALS provider. If they're going to take 10 minutes to get there and then probably another 10 minutes to do their assessment and to figure out what they want to do, you're delaying patients' care. You're there already. The hospital's 5 minutes away. You just took away 15, 20 minutes of their time, of that golden hour for a trauma patient. Do not give the patient anything by mouth, no matter how urgently you are asked. Remember, just let them know, hey, I'm sorry, I really can't give you anything. Or, hey, I don't have anything in the ambulance I could give you. They'll give you food as soon as you get there, as soon as the doctor sees you. Accurately record the patient's vital signs approximately every 5 minutes throughout treatment and transport. So that's going to be an unstable patient is every 5 minutes. Treating cardiogenic shock. Patient cannot generate the power to pump blood through the circulatory system. Chronic lung disease will aggravate cardiogenic shock. Patients in cardiogenic shock should not receive nitroglycerin. They are hypotensive. Patients usually have low blood pressure, weak, irregular pulse, cyanosis about lips, underneath fingernails, anxiety, nausea. Place the patient in a position that eases breathing as you give high flow oxygen. Assist ventilations as necessary. So remember, on a quiz, if they say any slow, irregular, shallow breathing, you're going to assist ventilations with the BVM. Provide prompt transport. Consider meeting ALS en route to the hospital. So this is another thing you could think about. If an ALS provider is halfway between you and the trauma center, you could call him. You can meet him if the ALS is 10 minutes away and the hospital is 15 minutes away. You could tell ALS to meet you en route. Provide calm reassurance to a patient with a suspected heart attack. Treating obstructive shock. For cardiac tamponade, increasing cardiac output is a priority. Apply high flow oxygen. Surgery is the only definitive treatment. So you guys need to get your patient to the hospital as fast as you can. Pericardiocentesis uses a needle to withdraw blood. Advanced skill, rarely performed in the field. So in some states, paramedics can actually do this. I think in Washington, they are allowed to do it because of how far away all the hospitals are. But we do not do it in the state of California. So for tension pneumothorax, apply high flow oxygen to prevent hypoxia. Chest decompression is required. Ask for ALS early in a call if available, but do not delay transport. So treating septic shock, hospital management is required. Use standard precautions in transport. Administer high flow oxygen. Ventilatory support may be necessary. Use blankets to conserve body heat. Use sepsis team if available. So we have a sepsis protocol in Monterey County. So if patient has any one of the following, an infection, a known infection or suspected infection, if heart rate's more than 90, if the patient is warm to the touch or the patient's has a body temperature 100.4 or more, we call for a sepsis alert if any two of those conditions are met. So treating neurogenic shock for the spinal cord injury patient, use a combination of all known supportive measures. Hospitalization will be required for a long time. So emergency treatment, obtain and maintain a proper airway. Provide spinal mobilization. Assist inadequate breathing. Remember, inadequate breathing means you need to breathe for them. Assist. BVM. Ventilate for them. Conserve body heat. Any type of shock, we're going to try and conserve body heat. Try and throw a lot of blankets on them. Remember, they're losing a lot of blood. Ensure the most effective circulation. Transport promptly. Treating anaphylactic shock. Administer epinephrine. Promptly transport the patient. Provide high flow oxygen and ventilatory assistance en route. A mild reaction may worsen suddenly. So remember, we're always reassessing our patients. We're going to make sure if they deteriorate or if they improve. We want to make sure that we're right there and we can act quickly. Consider requesting ALS backup if available. Treating psychogenic shock. In an uncomplicated case of fainting, once the patient collapses, circulation to the blood is restored. So in fainting or syncope, usually what happens is there's not enough blood that gets to the brain, which causes them to collapse. Psychogenic shock can worsen other types of shock. If the patient falls, check for injuries. If the patient reports being unable to walk after a fall, suspect another problem. Transport the patient promptly. Record all initial observations to try to learn from bystanders. If the patient complained of anything, how long the patient was unconscious. What was the patient doing before? Does the patient still feel like she's lightheaded? Is it a blood pressure issue? Is it a stroke issue? It's a cardiac issue. Has she been sick? Has she been eating and drinking okay for the past few days? So remember, you're always asking questions. You're always trying to figure out what's going on, what the patient could be suffering from. So treating hypovolemic shock. Control all obvious external bleeding. So any arterial bleeding, any other external bleeding, we want to make sure we get that under control. Keep the patient warm. Throw blankets on them. And remember, they lost a lot of blood, so we want to keep the patient warm. Recognize internal bleeding and provide aggressive support. Secure and maintain an airway and provide respiratory support. Transport as rapidly as possible. Treating respiratory insufficiency. Secure and maintain the airway. Clear the mouth and throat of obstructions. If necessary, provide ventilation with the BVM. Administer supplemental oxygen. Transport the patient promptly. Treating shock in older patients. The EMT must use caution when caring for older patients. Older patients may have more serious complications than younger ones. Illness is not just a part of aging. Many older patients take medications that mask or mimic signs of shock. So remember, you're always asking medications. And pharmacology is another good one. You want to understand how medications work, what they do for the body, what are the side effects. Because a patient with a low heart rate could be taking what are called beta blockers, the metoprolol. And some people might mistake it for a cardiac issue because their heart's not pumping fast enough. But understanding people's medications and how they work on the body and what they may do to the body can help you understand a little bit more about your patient. So the term shock is most accurately defined as So B, shock or hypoperfusion refers to a state of collapse and failure of the cardiovascular system or any one of its components. So remember, you got three components: the heart or the pumping, vasculature, blood volume, which leads to inadequate perfusion of the body's cells and tissues. Okay, so anaphylactic shock is typically associated with. So what are the signs and symptoms of an anaphylactic shock or an allergic reaction? So you're going to have vasodilation, right? You're going to have fluid leaking out of the blood vessels. You're going to have third spacing. And then you're going to have bronchoconstriction. And then you might also have hives. So what happens to your body when you start losing blood pressure? What's one of the signs of compensated shock? Increased heart rate, right? So probably not going to have bradycardia. So the first one's going to be A. Urticaria, hives. It's typically associated with allergic reactions, mild, moderate, and severe. They are caused by the release of histamines from the immune system. And anaphylactic shock urticaria is also accompanied by cool, clammy skin, tachycardia, severe respiratory distress, and hypotension. So remember, tachycardia, not bradycardia, symptom of anaphylactic shock. Signs of compensated shock include all the following except So do you guys remember that table that we went over before? All those signs and symptoms. So this is a bad sign right here. A feeling of impending doom, remember? That's going to be a sign of compensated shock. Restlessness or anxiety is compensated shock. So D, in compensated shock, the body is able to maintain perfusion to the vital organs of the body via the autonomic nervous system. Signs include pale, cool, clammy skin, restlessness or anxiety, a feeling of impending doom, and tachycardia. When the body's compensatory mechanism fails, the patient's blood pressure fails or falls. Weak or absent peripheral pulses indicate this. So when treating a trauma patient who is in shock, lowest priority should be given to So these are all issues we can solve or try and worry about. But what's going to be the lowest priority on here? So C, critical interventions for a trauma patient in shock include spinal precautions, high flow oxygen or assisted ventilation, thermal management, rapid transport, and early notification of a trauma center. Splinting fractures should not be performed at this scene if the patient is critically injured. It takes too long and only delays transport. So spinal protection. It's a trauma patient, right? So we're gonna have to stabilize them somehow. We need stabilization of the spine. So thermal management, preventing hypothermia is standard treatment. You want to make sure they got enough blankets to keep warm. So notifying the hospital. You want to notify the trauma centers early during patient interaction transport so they could call everyone that they need to do. They need x-ray, they need CT, they need trauma surgeons, they need extra nurses, they need to clear a room. Splinting fractures is going to take the lowest priority on a trauma patient who's in shock. So potential causes of cardiogenic shock include all the following except So C, cardiogenic shock is caused by inadequate function of the heart or pump failure. Within certain limits, the heart can adapt to these problems. Too much muscular damage occurs, however, as sometimes happens after a heart attack, then the heart no longer functions well. Other causes include disease, injury, and an impaired electrical system. So severe bacterial infections is going to probably fall under distributive shock because it's in the blood, and you're going to get the vasodilation. You're going to start losing fluids. So a 60-year-old woman presents with a BP of 80/60, a pulse rate of 110 beats a minute, mottled skin, and a temperature of 103.9. She's most likely experiencing what? Remember a few minutes ago I just talked about what protocol we have in this county. We have something more than 90 beats a minute, or a body temperature of 100.4, or a suspected infection. Sorry about that, class. So what kind of protocol do we have? A. Septic shock. Bacterial toxins damage the blood vessel walls, causing them to leak and rendering them unable to constrict. Widespread dilation of the vessels in combination with plasma loss through the injured vessel walls result in shock. A high fever commonly accompanies a bacterial infection. So there's also, patient could have a low body temperature for shock as well. So just because a patient has a suspected infection or documented infection and her heart rate's high and she's cold doesn't mean she's not septic. A patient with neurogenic shock should be least likely to present with what are the signs and symptoms of neurogenic shock? So C, in neurogenic shock, the nerves that control the sympathetic nervous system are compromised. The nervous system is responsible for secreting the hormones epinephrine and norepinephrine, which increase the patient's heart rate, constrict the peripheral vasculature, and shunt blood to the body's vital organs. Without the release of these hormones, the compensatory effects of tachycardia and peripheral vasoconstriction are absent. So a 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120 beats a minute, and his respirations are 30 breaths a minute. You should treat this patient for So D, the patient may have a liver laceration or ruptured spleen, both of which can cause internal blood loss. However, it is far more important to recognize that the patient is in hypovolemic shock and to treat him accordingly. So, like they were saying, you could have both. You could have lacerated liver or ruptured spleen. Does that really matter to you guys out in the medical field? The patient has a lacerated liver or ruptured spleen? Are you guys going to treat any differently for a liver or a spleen? Probably not. So you're going to treat for hypovolemic shock. He's compensating right now. His heart rate's 120, and he's got fast respiratory rate, 30 breaths a minute. Okay, so a 33-year-old woman presents with a generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her BP is 70/50, and her heart rate is 120 beats a minute. In addition to high flow oxygen, this patient is in most immediate need of So it sounds like an allergic reaction, right? She got stung by a hornet. Her blood pressure is 70/50. Her vessels are vasodilating. She's third spacing. Her fluid's leaking out of her vessels. Her heart rate's at 120 beats per minute. Her heart's trying to compensate for that blood loss. You could realistically do all these things right now. But what is she in most immediate need of? What's her most critical issue at the moment right now? So A, the patient has anaphylactic shock, a life-threatening over-exaggeration of the immune system that results in bronchoconstriction and hypotension after ensuring adequate oxygenation and ventilation. The most important treatment for the patient is epinephrine, which dilates the bronchioles and constricts the vasculature, thus improving breathing and blood pressure respectively. So she needs epi. It's going to help constrict the blood pressure, or excuse me, the blood vessels. It's going to increase her blood pressure. Okay. Yeah, she needs rapid transport as well, too. But epinephrine is going to come first. Okay. Antihistamine. You guys don't carry Benadryl. It's an ALS treatment. IV fluids. It's an ALS treatment. You guys can't give that. All the following are potential causes of impaired tissue perfusion except so what can be causes of impaired tissue perfusion? Pump failure. Your heart's not pumping enough blood. It's not getting enough blood out to the peripheries, to the extremities. So that could cause tissue perfusion. Low fluid volume. Not enough fluid in the pipes. So that could also cause impaired tissue perfusion. Poor vessel function. So patient has allergic reaction. The vessels are dilating. They're not getting enough fluid out to the extremities. Increased number of red blood cells. Doesn't really do anything for your tissue perfusion. So A, an increased number of red blood cells will allow adequate oxygen and nutrients to be delivered to the cells. So remember, red blood cells, they carry oxygen.